There you go.
All right. Thank you. So thank you for joining us today. Our presentation is getting started. So today we'll be discussing how to identify your patient your practice is responsible for and how to provide them with enhanced access to care. So this is our Practice Transformation Webinar Series 2. Feel free to chat in the comments and questions during the presentation. We'll answer your questions at the end. Also note that our previous session has been recorded and is on our website. We'll have a link to that later in the program. Gary, I'm going to turn it over to you for technical.
You entered the call today unmuted. You can use the controls on the bottom of the WebEx to mute and unmute your line. Please stay unmuted, or please stay muted as you are listening to the presentation today. We also welcome chat and questions during the presentation, as Tammy alluded to. Please use the chat box to type in your questions and comments throughout the session. You're on mute, Tammy.
Thank you. I was still muted. Thanks, Gary. Now a little bit about this series. Each session will be no more than 30 minutes long, as we know that time is a precious commodity. Each session will have time at the end for open discussion and questions. Because this is a small bite series, we will cover 1 to 2 foundational elements of practice transformation in each subsequent session. By taking small bites with each session, this will allow you to take small incremental steps in your practice. This series is designed with the small practice in mind, knowing you have limited personnel and financial resources. These are the steps in practice transformation. Just a reminder that these steps are not in a particular order. They are all done simultaneously. However, identifying your patients is truly the first step. Now, don't let this list scare you. It's important to note that your practice could implement only a small few of these steps and still effect change. It is not all or none, but the more invested you are in the changes, the more impactful your outcomes will be. Just a reminder that lower cost does not mean less care, just care in the right setting. If we improve outcomes, then long-term expenses should decrease. Now for some definitions. Active patients are those that you consider belonging to your practice. Each practice could define that differently, but it is generally patients that have been to your practice 1 to 2 times in the last 18 to 36 months. Empanelment is the process of assigning patients to providers or care teams, so you know who in your practice is responsible for their care. In many practices, this is done by patients stating who their primary care provider is. And access to care is generally ensuring that your patients have access to a care team member or someone with access to their medical record after hours. We are going to be talking about each of these in more detail throughout the presentation. Before we can talk about any of the other steps in practice transformation, it is important to first know who your patients are. So why is this important? As we shift to value-based care, your practice will be held accountable for care that happens outside of your office as well as inside your office. Thus, you want to ensure that you know who your patients are so that you can provide proactive care for them. You need to dig down into that even further to the provider or care team level so that no patient falls through the cracks because no one is dedicated to care for them. Now, let's talk more about how your practice identifies the patient you consider that you are responsible for. First, you want to establish a look-back period. Now, how far back will you go to determine what patients are active in your practice? Most practices consider this to be 18 months to 3 years. Many practices we work with use 24 months as the look back, as the maximum look back, because if you go back farther, you will find patients that you haven't seen in the last 2.5 years or so. And really, are those patients really your patients in receiving care from you if you haven't seen them in that long? If your look back period is too short, say 1 year, then you'll miss those patients who come to see you for a quick checkup yearly. Now, how many visits and what type of visits will you consider a patient needs to have in that time period to be active? Patients that sought care once for an acute condition might not be considered active patients, but patients that received one preventative care visit could be considered active. Now that you know what your look-back period is, you can run an empanelment report. In a perfect world, this would be a report that's already available in your EMR. In fact, it may not actually be. You may have to run a couple of different reports and combine them to get your actual empanelment. Once you run that report, you want to identify those active patients that don't have a PCP. And then how will you ensure that you know who their PCP is? Will you reach out to them proactively to see if they still have a PCP in your office? Or will you remove them from your active patient list after a certain period of time if they don't come in for a visit? If a patient presents who doesn't have a PCP listed, what will be your process for updating this field? For patients that have a PCP on record, it would be good to have a process to verify that information. Maybe they've switched providers in your office, but the record doesn't reflect that. Once you've determined who's responsible for what patients, you're ready to move on to the next step in practice transformation, which includes care management. We are going to talk about that more in the next session. So this is an example of an empanelment report. It is currently filtered to only look for patients with a visit in the last 24 months. We can see from this report that only 2 of the patients on the list do not have an empaneled provider. In your EMR report, this very likely could be worded as a PCP. It may not actually be worded as empaneled provider. It's important to distinguish between a patient's PCP or empaneled provider and the appointment provider. They may have seen other providers in the clinic for urgent issues or when their PCP was on vacation. However, this does not mean that the appointment provider is their PCP. The PCP is a provider that the patient considers their primary provider. It definitely has patient input. And looking closer at this report, we can see that Snow White visited the clinic last in 2018 for a sick visit. She might not be considered an active patient since she had only one visit and it was an acute visit. Therefore, when we talk about proactive outreach to patients, you would likely not include her in that outreach. However, Donald Duck was in the clinic just a few months ago for an office visit, so he likely would be considered an active patient, even though he does not have an empaneled provider yet. Now, your report from the EMR will look different and will likely offer many different ways to select fields to run the report. The report may have a different name, a different field titles, and that's what we're here for. Our consultants can help you determine what report in your EMR serves as your empanelment report, or help you combine a couple of different reports to get the data you need to identify your patients. So measuring success. Because it is important that patients have a designated PCP in order to ensure proper follow-up and outreach, it is important to measure if you're making progress in this. The first step is to establish your baseline empanelment rate. The empanelment rate is the number of active patients with an assigned PCP divided by the total number of active patients. And you can do this with your very first empanelment report to get a baseline. Now, repeat this report and calculation a few months after you have implemented a change. Has your empanelment rate improved? Now, remember, we're not assigning a PCP for the purpose of just assigning a PCP. You're assigning a PCP so that you know which care team should be providing care management and follow-up to those patients. A patient without a primary care provider might miss important tests and follow-up. Now on to access to care. Let's talk about why access to care is so important. Unnecessary ED utilization is an outcome that many payers are already examining and more will as time goes on. You want your patients to have the ability to avoid an ED for non-acute, non-emergent conditions. So here are some tactics that can be used to reduce unnecessary ED visits. First, you can improve access during current office hours, or you can expand office hours. If you don't already, you could provide after-hours access to providers in your clinic who have access to your EMR. And of course, we can't forget the role that patient education plays in reducing emergency department utilization. So let's start off by discussing access to your clinic during office hours. One way to assess patient access to clinic appointments is the third next available appointment measure. Full disclosure, this is confusing. That's why there's a reference at the bottom to the Institute for Healthcare Improvement. The third next available appointment time is the average length of time in days between the day a patient makes a request for appointment with a physician and the third available appointment for a new patient physical, routine exam, or return visit. The third next available appointment is used rather than the next available, since it's a more sensitive reflection of true appointment availability. For example, an appointment might be open at the time of a request because of a cancellation or some other unexpected event. So therefore, that would be a fluke. Using the third next available appointment eliminates these chance occurrences from the measure of availability. And the goal in primary care should be 0 days or same day. If you have same day availability, again, for routine appointments, then patients won't be forced to seek care in the ED for non-emergent conditions. The Institute for Healthcare Improvement, which is linked at the bottom of this slide, has a calculation methodology that you can look at for more information. Now, how do you improve on the third next available time? On the very same web page, there's a tool to help you assess your practice supply. This lets you see the distribution of availability by provider and other staff for patient care. Once you have this data, you can consider how you can adjust provider and staff schedules to better spread the appointment supply throughout the day and week. Perhaps you can stagger lunches so there's always an appointment over the lunch hour. However, you may find that you don't have the supply to meet the demand. If this is the case, consider adding early or late appointments a couple days a week. For more assistance on calculating the third next available and supply, you can reach out to us and we're happy to assist you. We can also assist you in redesigning your workflows to help you better leverage the providers and staff you have to improve that access. As always, we want to measure success with any change. To measure success in this change, you first want to assess the third next available appointment time right now, using the instructions provided on the IHI website. Next, implement a change in your practice to reduce that time. Now, in a couple of months, reassess your third next available appointment time. Has it changed at all? If it hasn't, what can you do at your practice to shorten that time? What other interventions can you do? Now we're going to move on to another way to reduce unnecessary emergency department utilization. So another way to improve access is to offer access to your care team after hours. If you currently have access to members of your care team after hours, it's important to assess if patients realize that. If they don't, and they have something that they feel is urgent, they're likely to head to the ED. However, if they know you're available after hours, then they are likely to pick up the phone and call the office first. We all know that many ED visits are for non-emergent conditions that can wait to be seen in the clinic the next day. But do your patients know that you have after-hours access? As a practice, you may think, everybody knows they can call us, but in fact, many patients may not actually be aware of that. So a fun, easy way to determine if patients know you have after-hours access is a fishbowl poll. You can set this up on a card table in the corner of your waiting room or even at the check-in window if you have space. And you can actually use this for any number of polls. Simply post a question of what you want to know. So in this case, the question is, did you know that you can reach a provider after hours by calling the office number? Now put out a fishbowl or other receptacle for each answer and label each fishbowl. I didn't have fishbowl, so I used mason jars. And then you provide some kind of a vote token. So in this case, I just had some glass beads. You can use golf balls or ping pong balls or anything like that And then a person just takes one of those tokens and puts it in the yes or the no receptacle to cast their vote. And it's very visual and you can see it. It's quick and it's fun. And it's just a really easy way to get feedback for a simple question. So now let's explore some ways that you can make patients more aware of where to seek care. First of all, if you do have after-hours access, you need that to be everywhere possible so that a patient can see it so they remember it when they actually need it. So you're probably giving patients a paper copy of their after-visit summary or some other kind of paper discharge instructions. So consider including your after-hours access on this document, even if it's sent electronically. A great place to post flyers is in the exam room so they can see it while they wait to see a provider. How about posting a laminated copy on the back of the restroom stall door? And you know you have their undivided attention when they're there. If you call patients for ED follow-up and their condition could have waited for an office visit, take that opportunity to ask them if they knew that you had a provider available and then educate them about that for the next time. And be sure that your hours and how to contact you after hours is on your website, especially for new patients that are just wanting to establish care with your practice. And many of your patients use social media, and your practice probably does too. So use that platform to remind your patients on a regular basis of how to get in touch with you after hours. You could also leverage your portal or text messaging functionality to send out reminders a couple times a year, just updating patients on your availability. Even if you don't have after-hours access, it's important for your patients to be able to distinguish between emergent and non-emergent symptoms. So consider creating a pocket card or refrigerator magnet that has a list of symptoms grouped into columns such as this is when you go to your primary provider, this is when you go to urgent care, and this is when you go to ED. There's some great templates for this out on the internet that you can use to get started. And again, our consultants can help you with that as well. Again, that's good information to add to your website as well. And with this information available, a patient may decide to forego an ED visit and wait to be seen in the clinic the next day. And that's our goal, for them not to go to the ED for something that can wait. So, how do you know that your interventions to reduce ED visits have made a difference? First, look at your baseline data. You likely get an ED visit notification from local hospitals. So you can look at that data and sort that data by reason for ED visit and time of visit. So with that data, you can determine what percentage of visits were made to the ED when the office was open, or visits that could have waited until the office was open. We want you to implement one of the tactics we talked about to improve access to care and education, and then reevaluate your ED visits in like 3 or 4 months later after implementation. And see if you see a reduction in percent of visits that could have been seen in primary care. Now, you may not get ED visit notifications from your local hospital, but this would be a great reason to reach out to them and see if you can establish some kind of contact with them. We will be discussing this more in an upcoming session as well. As we've stated before, the first step to practice transformation is determining who your patients are. In the next 2 weeks, before our next session, run a report from your EMR to see how many patients have an assigned PCP and how many patients have not been to your clinic in the last 24 months that you can perhaps eliminate from your active patient list. We're going to be discussing what to do with that list of active patients in our next session. Also, implement one tactic to either improve access or educate patients about where to seek care. Which tactic that we talked about makes the most sense for your practice, and what will work best for you? Again, we encourage you to reach out to us as you're working on these next steps. We can assist you in determining the best way to get your data, how to analyze it to benefit your practice. We also can provide resources and templates for patient education. Now we're going to address any questions that have been put into chat, and we're also going to open it up from questions from the audience. So if you have a question, please come off of mute or type it in the chat. Vicki, do you have any questions for us?
No, I do not. Very nice.
Okay, perfect. Thank you. Then I'm going to move on to the next slide. We're going to give you back some time in your day, which is always nice. So just letting you know that we have consultation services available for you. This is tailored support from our consultants. We work with workflow and process analysis, data analysis, and HIT consultation. So really helping you to look at your workflows, look at the data you have, how to leverage your EHR to really improve everything you're doing, improve your efficiencies, and help you to really tap into all the resources you have. And this is free for eligible practices. If you're contracted with any of the 3 MCOs in the state of Kansas, we can provide this service to you for free. So you can learn more by emailing us at practices@kfmc.org. You can also visit our webpage. This webpage also has links to the slides and the recording of previous sessions, so you can go back and see what else we've talked about previously. So our next session is going to be November the 3rd. So on November the 3rd, we're going to talk about utilizing care management services for high-risk patients, and also how to use team-based care to improve care delivery. And this is just information on how to contact our team, both myself and Gary, who you heard earlier. And then we do have a post-event survey, and this will be emailed to you after the event, but we really want to hear your feedback. We want to make sure that the webinars that we're providing to you are relevant to your practice, and we want to know what we can do to improve them. So with that, that concludes our webinar. Thank you, everyone, for attending.
Sure.
Thanks. Have a good day.